afternoon, everyone. Thank you, cheers. First of all, I'd like to express my gratitude to SGI, Dr. Manoj Sao, Dr. Avinash for giving me this opportunity. I'll be talking about how endoscopy is changing the treatment strategy of IBD. Now, this slide, I would say, is a very interesting slide. It is my favorite slide for January 2021. And why so? Because I think it captures a huge amount of ethos and pathos. It captures the imagination of mankind. It captures the immense scientific breakthroughs which have been made, and it captures also lots and lots of hope. It shows that how vaccines which took around 150 years to be generated, and in fact hepatitis B vaccine also took around 20 years to be generated, and now we have SARS vaccine which was generated within 6 months to 1 year, showing the immense progress which has been made in science. And this progress has not only been made in the field in biology or other fields, but in practically every field. And I use this slide as an example to show that how in the field of IBD also, endoscopy is changing the treatment paradigms. It is changing the way we are looking at how to decide the next course of treatment. I'm not going to focus on therapeutic role of endoscopy in IBD. I'm going to focus on the renewed avatar of IBD in endoscopy, that is as a diagnostic tool, how it is going to change the way we are going to treat.
We have had many scoring systems from last 4 to 5 decades, starting from Barron, Mayo and UCCIS to UCEIS, all of them trying to improve upon the previous score in terms of reliability, validity, looking at endoscopic images from different points of view. But essentially what we have witnessed in last 3 years is a conceptual change. What we were looking for earlier was validated and perfect scoring system. Now the direction has changed. The target has moved. Endoscopic scoring systems earlier were thought to be purely for mainly clinical trials, research settings. And clinicians often asked, what is the utility of endoscopic scoring system in practice? And what was seen was that if we could use endoscopic scoring system, and if it could be a useful treatment target, an objective target which could predict the further disease course, and obviously it was clearly seen that endoscopic remission plus clinical remission, or what is termed as deep remission, was superior to only clinical remission. And mucosal healing became the new target. It was a stringent endpoint of remission and predicted both short-term outcomes as well as long-term outcomes. Move a step higher. Why only deep remission in terms of endoscopic remission plus clinical remission? What happens if a patient has endoscopic remission plus histological remission? A recent meta-analysis looked at it. In patients with ulcerative colitis, what is the incremental benefit of achieving endoscopic and histological remission? And what they saw was that Mayo endoscopic score of 1, the annual risk of relapse was 29%. The moment MES moves to 0, MES Mayo endoscopic score of 0, the annual risk of clinical relapse dropped to 14%. What happened when patients of MES of 0 or complete endoscopic remission also had in addition histological remission? It was seen patients who achieved histological remission along with endoscopic remission, they had a 63% lower risk of relapse as compared to patients who had endoscopic remission but no histological remission. So while the world was talking about treat to target, definitely many of the people were already aiming towards treat to clear. Treat to target was clinical remission, endoscopic remission. Treat to clear, clinical remission, endoscopic remission, histological remission. And so obviously endoscopic scoring systems, if they could talk about mucosal healing, they were definitely useful in clinical practice. However, the gap out here was that you wanted to increase the reliability. You wanted to reduce the variability of scoring system. There was an observer which was out there who was scoring. And obviously there would be an inter-observer change in differences in how they would score. So the concept of centralized reading was introduced. This study in gastroenterology around 8 years back clearly shows or highlights the importance of centralized reading. This is a randomized control of Asacol versus placebo in patients with ulcerative colitis. When centralized reading for endoscopic images was not used, what was seen was the result at week 0 was not significant, result at week 10 was significant, and the result at week 6 and 10 was not significant. The moment centralized reading was used, it was seen that week 0 result was also significant, week 10 result was also significant, and week 6 and 10 result was also significant, clearly showing that centralized reading is obviously much superior in terms of whenever anybody is doing clinical trials in terms of looking at results and all. Yet at the same time, there were certain challenges which are there with centralized reading in IBD. And this review clearly highlights the challenges. There are certain deficiencies. The deficiencies which cannot be made up for are if there is like at the acquisition stage, at the make of the endoscope, the model of the endoscope, whether it can really pick up those images or not. Centralized reading clearly cannot improve upon the limitations of the underlying score. So keeping these limitations in mind came up the issue that if you are going to look at mucosal healing, obviously what one would want is a precise and detailed real-time assessment of the mucosal healing. And this is more than ever required. How is one going to achieve it? Artificial intelligence was already making its inroads into practically, I would say, every system of life. So why not IBD? Why not endoscopy in IBD? Professor Nakase's review, Professor Nakase from Hokkaido and his team, and this review has very beautifully highlighted it. Artificial intelligence is basically how you teach the computer to think like a human being. And if you're going to teach the computer to think like a human being, then the process by which you make it happen is known as deep learning. Deep learning relies on making a lot of networks like human neural systems, layers and layers of networks. So came up these terms into the domain of an IBD endoscopist also. Machine learning, which is part of artificial intelligence. Deep learning, the process by which artificial intelligence can be developed. Deep learning would be dependent upon neural networks. The essential difference between machine learning and deep learning is machine learning, the data is extracted or the features are extracted by human and subsequently classified and output data is generated. Whereas in deep learning, the feature extraction, the classification, regression, and the formation of subsequent neural network system, human beings are not involved. It is all computer aided. So we have two terms which we have to be very conversant with, because an IBD endoscopist would end up using these terms much more, many more times in future. That is CAD, computer aided diagnosis, and CNN, convoluted neural networks. So based with this foundation, the requirement was, let's have operator independent computer aided diagnosis of endoscopic activity in ulcerative colitis. And the first of the large studies which came up was in 2018, which came up from Japan, and it looked at around 840 patients of ulcerative colitis, around 26,000 images, made a convoluted neural network, and subsequently it was validated in another set of 114 ulcerative colitis patients. And what you can clearly see that it was able to very well distinguish between Mayo 0 from Mayo 1 and Mayo 1 from Mayo 2 and 3. And that is what one wanted. However, at the same time, as human beings, we always want to achieve higher. So what was the next gap which was seen out here and people wanted to achieve was, yes, computer aided diagnosis seems to help in terms of differentiating Mayo 0 from Mayo 1 and Mayo 2 and 3, but it does not tell us anything about histology. And today we are already talking about adding histological healing to endoscopic healing in our long-term treatment goals. So why not have a routine high-quality integration of endoscopic and histological scoring? And this was shown by this study, which was actually based more, I would say, on machine learning, and this looked at a concept what is known as red density, the redness of the images and the vascular intensity of the images. And on the basis of this multi-center study with the Belgian group, the Leuven group, and the Japanese group, they formed the networks, and this RD score was found to be an operator-independent computer-based tool to determine disease activity in patients with ulcerative colitis. This is the normal white light image, and this is the red density image. And this RD score was shown to be correlating very well with endoscopic activity, and not only that, it correlated very well with histological features of ulcerative colitis. Obviously, the time was all set where you wanted creation of an artificial intelligence machine, learning based deep neural network, which is capable of assessing endoscopic and histological disease activity based only on endoscopic images. This landmark study, I would say, from Professor Mamoru Watanabe's group looked at it. They developed a deep neural network for evaluation of endoscopic images from patients with ulcerative colitis. They called it as DNUC, and it identified patients in endoscopic and histological remission without the need for biopsy analysis. Obviously, this was a big up. So the study design was very simple. They picked up lots and lots of images of endoscopy. They also had histological images, put them in a computer, and subsequently the output was in terms of looking at endoscopic remission as defined by UCI score of 0, histological remission as defined by GIVO score of less than 3, and overall what are the components of UCIS score. There were around 8,000, 7,500 or 8,000 patients of ulcerative colitis, 40,000 colonoscopic images, and 2,000 patients of ulcerative colitis and 8,000 histological images, 40,000 colonoscopic images. They had initial development cohort, formed the deep neural networks. Subsequently, they had a validation cohort of around 115 ulcerative colitis patients, and look at the results. 90% accuracy for determining endoscopic remission in comparison with experts, and 92% accuracy for predicting histological remission without the need for mucosal biopsy. Clearly, this study has ramifications. This study not only shows that AI-based systems, when they are, or endoscopic scoring systems, when they are developed, or the deep neural networks are developed, they would be helpful in clinical trials. They would replace central readers. They would optimize efficiency. They would avoid the video equipment for histological slides. They would avoid the misclassification. These DNUCs would be very helpful for provider training. They may in future be incorporated into GI training curriculums. In disease management, they would improve the cost effectiveness, avoids the need for biopsy. At community practice setting in future, they would avoid the need for GI pathologist. So obviously, this is a whole paradigm shift or a conceptual change. When we talk about progress in endoscopic scoring system, or we talk about endoscopic system, it is not endoscopic scoring system, but endoscopic scoring system and AI assisted endoscopy. And we have many scoring systems which are come up, which are differentiated on the basis of their range of assessment, and also whether they correlate with histological inflammation or not. So this has been the major advancement. Besides that, we have also been, people have been looking at refinement of predictive ability of endoscopic scores in ambiguous situations. One such is Rutger score. Rutger score is a very robust score, looking at post-surgical recurrence of Crohn's disease, a validated score, a score which has stood the test of time. And everybody uses it. Clearly, it has been able to predict the symptomatic recurrence based on whether it is I0, I1, I2, I3, I4. However, it was felt that there is some ambiguity when it comes to I2, and so it was decided that this needs to be dissected, and came up what is known as modified Rutger score, where I2 is a lesion confined to the anastomotic site mainly, whereas I2B is a lesion which is confined mainly to the neoterminal ileum. So whether there is a difference in terms of symptomatic recurrence in I2A lesions versus I2B lesion, came up a retrospective study. This retrospective study from Leuven Belgian group showed that I2A versus I2B, actually there was no difference in the need for endoscopic or surgical intervention, or in terms of looking at recurrence from those kind of outcomes. Yet this year, a prospective study has come up, a French multi-center study from the REMIND group. This looked at post-operative endoscopic recurrence and found that patients who had exclusively ileal lesions in the neoterminal ileum, they had poorer clinical long-term outcomes than patients who had exclusively anastomotic lesions. So clearly suggesting there is room for modified Rutgers score. In acute severe ulcerative colitis, whether when we use ulcerative colitis endoscopic index of severity, it can play a role in predicting. So whether you can predict short-term outcomes, the steroid failure after 5 days of IV steroids. So if you look at UCIS score at admission and also at fecal calprotectin to it at various days, we did a prospective study and found that fecal calprotectin of more than 1000 at day 3 and UCIS more than 6 at day 0 predicted 100% failure to IV steroids. This has been subsequently validated also in another study, and this study shows that actually this model is quite robust and is comparable to Oxford day 3 criteria for predicting short-term outcomes. In terms of positive predictive value, it is much more than Oxford, and overall specificity is also more than the Oxford index. If I were to summarize the recent progress in the endoscopic scoring system, I would say that you would all agree also there has been a conceptual change. Earlier, you're looking at scoring systems which are reliable and validated. However, the need was felt for observer reliability. Centralized reading was the solution. The need was felt for whether endoscopic scores could be incorporated in daily clinical practice in terms of could they be relevant. Came up the concept of mucosal healing. The gap was that you wanted precise and real assessment of mucosal healing. How are you going to achieve it? Obviously, the solution lay in artificial intelligence. That was used by IBD endoscopists. So you had operator-independent computer-aided diagnostic systems which have come up, which map the endoscopic scores. However, the gap out here was that what about histological inflammation? With the help of endoscopic images, can't we look at not only the endoscopic remission but also histological remission? And so you have the deep neural network based artificial intelligence system, and clearly the biggest conceptual change which has come up is that artificial intelligence based score, which is not observer biased, does not require central reading and can tell endoscopic as well as histological remission. Thank you very much for your attention, please.
Good afternoon, friends. Today we are going to discuss about the colonic ulcers beyond TB and IBD. Colon ulcers are on the lining of the colon, often surrounded by a ring of red inflammatory changes of variable size and irregular shape. Now, most of the time it is the IBD or the tuberculosis. However, there are other causes of the colon ulcers. That's what we are going to discuss now. So most of the time we can see NSAID related colon ulcers. Very frequently we used to have the NSAIDs in the population. The chronic use of NSAIDs are surfaced as a growing problem. The adverse events like inflammation, ulceration, and stricture of the stomach, small bowel are already seen. At the same time, the colonic ulcers, relapse of the IBD, complications of the diverticular diseases including hemorrhage, fistula formation are other parts of this growing problem. NSAID-related ulcers, of course we should know the span of the exposure of the NSAIDs has ranged from the 2 days to 12 years with the median of 3 months. The classic symptoms, which are often non-specific, can include even abdominal distension, GI bleeding, discomfort, and weight loss. The pathophysiology remains speculative till today. Maybe there is a NSAID-induced colopathy that starts with the increasing permeability. There is damaging action of the mucosal membrane, and ultimately we have got the permeability increase in the mucosa. There is uncoupling of the oxidative phosphorylation, efflux of the ions, and the resulting more damage to the mucosa. Additionally, with the increased permeability, cells are exposed to the proteolytic enzymes, and the bacterial invasion, neutrophil chemotaxis can lead to further damage and eventual ulcer formation of the colon. The prevalence of the GI disorder of the chronic NSAID users, crude prevalence rate for gastro ulcer is 13% and duodenal ulcer is 11%. At the same time, the same study shows that almost 3% of the patients, they have got the colonic lesions, including the ulcerations. Of course, the endoscopic findings may be variable, mild proctitis to ulcerative pancolitis. We can have the erosions, linear ulcers, scattered areas of the ulcers and the cobblestoning. There is surface hemorrhage, there is submucosal edema with the hemorrhage as well. These are the pictures of NSAID-related ulcers from different parts of the colon. Then we have got the amoebic ulcers of the colon. Of course, Entamoeba histologica is a worldwide distribution. The symptom from this problem may vary from dysentery with diarrhea to rectal bleeding, mimicking IBD. There may be liver abscesses, colonic granulomatous mass can be seen mimicking a carcinoma, or also it has got the complications like colonic perforation or the fistula. There are three virulence factors known to influence the pathogenicity of amoebic ulcers. With the N-acetyl galactosamine, which inhibitable lectin, and they are responsible for the host cell adhesion and the destruction. There is a amoebapore, which are small peptides that facilitate the killing of the host cell again. And finally, we have the cysteine proteases. These enzymes facilitate the lysis of the host extracellular matrix. As the pathology progresses, the colon mucosa becomes diffusely inflamed edematous with increased associated necrosis and sometimes the ulcer perforation of the intestinal wall. The classic endoscopic picture, the discrete areas of the ulcers, which is covered by the exudates with the normal intervening mucosa, but sometimes it may depart from this particular description. The amoebasis may involve any part of the bowel, but it has a predilection for the cecum and the ascending colon. These are the colonoscopic pictures of amoebic ulcers. Any part of the colon may be involved with the predilection of the right side of the colon. This is the amoebic ulcer histology, where you can see the amoebic trophozoites containing digested red blood cells and flask-shaped ulcer. The challenging job is the diagnosis of amoebic ulcers. The detection of the trophozoites of Entamoeba histologica with the ulcers in the microscopic picture from the colonoscopic biopsies, this is the gold standard. More infrequently, we can get in fresh stool examination. And of course, in the patients with diarrhea, most likely we can get the trophozoites in the stool. There is segmental distribution of the sites involved the amoebasis, Crohn's disease, and ulcerative colitis. This picture shows clearly the amoebasis, mostly it is colon and ascending colon. The ulcerative colitis, mostly in the descending colon, then we have got the sigmoid, rectum, and Crohn's disease, mostly it is the ileum involvement. This histological changes again showing the picture with amoebic colitis, then ulcerative colitis and Crohn's disease details. I am not going now. Next, we have got the malignant ulcers of the colon. Of course, colon ulcer can present with the large ulcerated lesions like this. At the same time, I also discuss the solitary cecal ulcers, which are usually 50% of the colonic ulcers, mainly cecal ulcers, found in the cecum are generally antimesenteric, and it is 2 centimeters away from the ileocecal valve. And the etiology in most of the cases, it is the malignancy, and also it may be NSAID related. The incidence of sickle carcinoma amongst these patients are also quite high, up to 8% of the cases. We should suspect malignancy if the size of the ulcer is more than 2.5 centimeter, irregular and crater-like appearance with the irregular borders. These are the colonoscopic picture with the histology where it is the sickle ulcer with pre-malignant histologic picture. The presentation of the solitary sickle ulcers are non-specific. It is localized abdominal pain in the right lower quadrant, bleeding, constipation, diarrhea, and all. We can get it from here. Next, we have got the solitary rectal ulcer syndrome, which is very popularly known as SRUS. It is a chronic, benign, underdiagnosed disorder. It is characterized by single or sometimes it may be multiple ulcerations of the rectum, even in sigmoid colon may be involved. There is passage of blood and mucus associated with the staining or the associated abnormal defecation. The average time from the onset of the symptom to the diagnosis is almost 5 years too long. The pathogenic mechanism of the SRUS may be the mucosal prolapse, there is venous congestion, there is a poor blood flow and edema of the mucosal lining in the rectum and sigmoid colon, then leading to ischemic changes, and finally it leads to the ulcerations. Of course, the pressure by anal sphincter can precipitate for the ulcer formation. The self-digital maneuver of the reduced rectal prolapse and to evacuate an impacted stool may also cause the direct trauma of the mucosa and the ulceration. Endoscopic view, it's range from 0.5 to 4 centimeter, and usually it is 1 to 1.5 centimeter ulcers. The appearance may vary from hyperemia to established ulcers, and which is covered by yellow or white yellow slabs. The ulceration is shallow, and the adjacent mucous membrane may appear nodular, lumpy, or sometimes granular. And importantly, 25% of the ulcers may appear as the polypoid lesions, 18% may appear as a patchy mucosal erythema, and 30% as the multiple lesions. These are the pictures, colonoscopic as well as the histology for solitary rectal ulcer syndrome. Then we have got the typhoid ulcer of the colon. The endoscopic demonstration of the lesions of the typhoid or by colonoscopy is scarcely seen in the medical literature because it is done at the end of the whole investigation when you cannot get the final diagnosis. The colonoscopic manifestations are multiple variable size punched out ulcerations, usually ovoid side, shaped, soft edge, swollen and irregular, not undermined, and floor may be formed by the muscular cord. The ulceration generally seen in the terminal ileum. However, it can seen sometimes in the left side of the colon. Of course, the cecum and ascending colon can be involved very frequently. These are the, again, colonoscopic as well as histologic pictures of the typhoid ulcer. This picture, the slide shows the location, inflammation, ulcer pattern in case of typhoid, bacillary, and amoebic ulcerations of the colon. Then we have got the non-specific ulcers. The non-specific colon ulcer is of unknown etiology. More than 50% of these ulcers are located in the right side of the colon near the ileocecal valve, and approximately 20% are usually multiple. Non-specific ulcers, usually the simple ulcers of the GI tract is one of all kind of ulceration that have been ruled out. Because when you rule out, then only you can put the diagnosis that it is a non-specific ulcer. Non-specific ulcer may occur at any point of the GI tract. Again, the diagnosis is based on the histological findings showing non-specific inflammatory changes. The radiological imaging can help us to locate the lesions, but colonoscopy is the final diagnosis of the ulcers. The potential of the non-specific colon ulcer to recur is currently unknown, but the morbidity rates are quite high. We have got the radiation proctitis, where we have got the different risk factors after to have the radiation proctitis after radiotherapy. The elderly age group, prior abdominal surgery, history of PID, hypertension, diabetes, thin physique, administration of the chemotherapy along with the radiotherapy, and also some other causes like collagen vascular diseases. The acute radiation proctitis is seen almost 75% of the patients treated with the pelvic radiotherapy. It occurs during the treatment or after several weeks of the completion of the radiotherapy, but usually it is of mild symptoms. Physiologically, mainly pathophysiology, it is the transient mucosal atrophy, submucosal edema. Also, there is inflammation of the infiltration of the lamina propria with the neutrophils and the plasma cells. We have got the ischemic ulcers. The ischemic ulcers to the rectum is usually rare owing to the rich vascular supply of the area. But in clinical practice, we can sometimes see it with the risk factors of the major vascular occlusive diseases, disruption of the collateral circulation, and also the low flow state of the area. Ischemic colitis is an occlusive or non-occlusive disease, and usually it can be seen along with the atherosclerosis, diabetes, cardiovascular disease, vasculitis, hypercoagulable states, and hypertension. Then ischemic ulcers colonoscopy picture is a gross inflammatory changes, edematous friable mucosa, mucosal ulceration, erythema, pseudomembranes, and sometimes there is interspersed pale area. The biopsy shows the non-specific changes such as the hemorrhage, crypt destruction, is capillary thrombosis, granulomation, tissue formation, and sometimes there may be pseudopolyps like Crohn's disease. These are the colonoscopic as well as the histologic pictures of the ischemic ulcers of the colon. Then finally we have got the pseudomembranous colitis. Pseudomembranous colitis is a very serious inflammatory changes of the colon, and it is characterized by the elevated yellow-white plaque formation, what we call the pseudomembrane formation. It is commonly attributed to the bacterium C. difficile, and it is commonly affect the middle-aged and the elderly-aged population. Reported incidence of almost 15 to 20% of the patients who takes the broad-spectrum antibiotic for a long time. Then again, the presentation is usually mild, cramping pain, fever, and diarrhea, and the complications can ultimately lead to the fulminant colitis, toxic megacolon, perforation, and the bleeding. C. difficile, which is a part of the pseudomembranous colitis, the risk factors with the elderly age, antibiotic use of medicines that reduces the immune system, recent surgery, history of the pseudomembranous colitis, and history of the IBD. The microscopic picture, elevated yellow-white nodules or plaques, erythematous, friable, and the ulceration formation. There is small areas of the necrosis, and of course, the pseudomembrane formation. These are again the colonoscopic pictures as well as the histologic pictures of C. difficile pseudomembranous colitis. So this is what we wanted to discuss about. The conclusion finally, the ulcers in the colon is not ends with the TB or the IBD. There are many more causes of colon ulcers. Few of them we discussed here. Due to time, probably we cannot discuss all the ulcers so far we have got. With this, I thank all of you for your kind attention. Thank you.
Thank you, Dr. Goswami. So, at the outset, I would like to thank the organizers to give me this special opportunity. And it is indeed a special opportunity for me to moderate the session on IBD, on which the first talk was by my mentor and my teacher, Professor Vineet Ahuja, who, as usual, was excellent. And every time when I listen to his talk, there is something new in it. It's thought provoking, it's very lucid, and it is very coherent. And he very well covered the aspects of endoscopy related to IBD and the important and the recent developments which would be useful to us in the coming times. And I would also like to congratulate Dr. B.D. Goswami for his excellent talk on a topic in which our minds often close on TB and IBD when we evaluate a patient with colonic ulcer. So he has broadened our differentials with relation to these ulcers or to these findings whenever we see a patient. So now I would also like to introduce the esteemed panelists and moderators for this session. So we have Dr. Deepak Suvarna from Suvarna Hospital, Mysore. We have Dr. Atish from Chennai, and we have Dr. Adarsh from Kasturba Hospital, from we have Dr. Adarsh from consultant gastroenterologist from Bangalore, and Dr. Atish Shetty, who is assistant professor at Kasturba Hospital, Manipal. And our moderators are Dr. Jaydeep Sarkar from Kolkata, Dr. Joseph Babu from consultant gastroenterologist from Chennai, and Dr. Amitabh Roy, consultant gastroenterologist from Tripura. So to start off with this session, I would like to ask Dr. Deepak as to what do you think would be the treat to target strategy is a lot been talked about, and it is being considered as the new thing in IBD, and like diabetes or like hypertension, the treatment goals are moving from just clinical or endoscopic revision to advancement in these targets. So what would you think at present would be the treatment target for ulcerative colitis? What would be the treatment target for Crohn's disease? And what do you follow in your practice? Dr. Deepak, please.
Yeah, so once we make an assessment of the treatment, what is the disease, what stage the patient disease process is in, then we would actually treat this patient with the regular medicines. If the patient is having, say, severe colitis, we would actually begin with steroids and then step down as the patient improves to maybe 5-ASA and then and so on. If the patient is not responding, maybe with steroids in the next time, we would actually add azathioprine and then build up the thing. So based on the patient's recovery, the step down process can be initiated with 5-ASAs to continue.
Yeah. No, so for the do you aim at clinical improvement only, or do you aim at, say, go beyond that and do you aim at endoscopic improvement in a patient with ulcerative colitis?
Well, we would actually aim for a mucosal healing with all these medicines. And once the patient improves, maybe as per the protocols, we would actually do a colonoscopy and then see whether the patient is actually improved to continue these medicines or not.
Okay. And for patient with Crohn's disease?
Patients with Crohn's disease, most of the times, of course, we will have to continue these medicines, and the patient, if he is responding, fine. Otherwise, we'll have to step up with medications with steroids, and maybe if there are complications like fistula or complications like that, we would have to put them on infliximab or other biologicals.
Okay. Thank you, sir. So Dr. Adarsh. So now, what do you think between endoscopic and histological remission for ulcerative colitis? So the evidence is coming up that endoscopic remission leads to better outcomes and histological remission leads to even better outcomes. So at present, do you think that we should aim for histological remission, or we should limit ourselves to endoscopic remission, or we should just follow the practice of clinical remission? And secondly, with the advent of AI, as Sir talked about, do you think that this will improve our management with respect to treat to target strategy?
Yeah, I think our aim should always be mucosal remission, histological remission per se. Most of the time, yes, we are happy with clinical and endoscopic remission, but yeah, we do regular surveillance to make sure that patient has achieved histological remission. So that would be our target as of now. And coming to the second part, yes, artificial intelligence, I think it is going to make our job easier and then more stratified and more uniform way. Basically, every person uses subjective scoring systems. I think with AI, I think that will become more objective and it will make our job easier. I think, yeah, I think it's coming up. I mean, definitely we don't have experience, but looking at the data, it's very encouraging.
Yeah, Dr. Atish. So, so if you target endoscopic remission for your patients, then how frequently do you monitor them? For example, if a patient is being started on a particular therapy, then at what time point would you prefer to do a repeat endoscopy or any other investigation to look or to achieve your target?
If a clinical remission he has achieved, yeah, as a part of protocol, maybe at the end of 8 years for surveillance for dysplasia in a proctosigmoiditis or left-sided sigmoiditis or a pancolitis, to look for any dysplasia, we would do at the end of 8 years surveillance as part of surveillance for colorectal dysplasia or colorectal cancer screening.
Yeah, but for like we are talking about the target treat to target approach. So do
maybe initially clinical symptoms as well as biochemical, the C-reactive protein and rest. If there is the end of 1 or 2 years, a sigmoidoscopy based on patient whether he's having in remission or relapse. Maybe at the end of 2 years, do a sigmoidoscopy or a full length colonoscopy.
Yeah. So, so my question to Dr. Vineet. So, sir, what are your thoughts on the treat to target strategy in ulcerative colitis and Crohn's disease, and what, according to you, should be the target, and how do we achieve that, and how frequently do we monitor?
Yeah, I think as the panelists have very rightly said that mucosal healing should be the target, but it remains still a very theoretical thing at the moment. It remains more a part of clinical trials and in research settings because actually for ulcerative colitis, we do not have any prospective randomized control trials. So the experts are very right when the panelists are very right when they say that yes, everyone is advocating it, that we should do endoscopy after 6 months and then see whether endoscopic healing has occurred or not, even if the patient was already doing well. So the problem is that it is not very easy to apply. It is not very practical. So I would say it would take another few years before it comes into real life practice. There is some data, one study available for Crohn's disease. So in Crohn's disease, you can say the threshold would be lower. You can go in for mucosal healing, but overall, it is very tough to implement at the moment. So this is a concept which is coming up and may take another 2-3 years before it comes into proper clinical practice. That would be my take on it. Maybe Dr. Goswami, what do you feel like?
I think you're very correct about it. Probably it is not yet very practical in the say all areas, in the remote areas when a gastroenterologist cannot accept it at the moment. Probably it will take some more time to come to the practice. And another point I wanted to just ask about. So what you were mentioning about the treat the target and coming to now the treat to clear. So is there any chance in future so that we can predict if it is coming to treat to clear, or is there any prediction in future probably think of that after some time, for a long time, if it is in remission, say for example ulcerative colitis, so that we can stop the medication. Is it possible in future?
Yeah, treat to clear also tells that in addition you have histological remission. And in the phase 3 trials of ustekinumab, So they looked at one of these objectives also, whether the patient got clinical remission, endoscopic remission, as well as histological remission, and subsequently showing that, okay, with histological remission, in addition, the long-term results are better. But to implement all these things, as you said, in fact, I remember like last year before the COVID epidemic, and that was the last one of the last face-to-face meetings we had, and that was in Guwahati. Every year, Dr. Goswami holds a meeting, and
There's
there
a
you
topic, treat to target. That is your topic.
and we asked the audience at the end of the talk, if you remember, that most of them said, it is very difficult to apply. So as a concept, yes, we should know about it. It is getting applied in not even all Western countries. It is not getting applied. So gradually it will take its place into clinical practice. So that is where I think we stand today.
Yeah.
So is it possible that we can actually decrease the medicines if the patient achieves a histological remission, or stop it even? Is it possible?
Yes, you can if the patient achieves mucosal healing, and you may decrease the medicines. If the patient is on biological therapy, you may think of an exit strategy whereby you continue the patient on azathioprine and reduce biologics. Then there's a 50% chance of relapse in 1 to 2 years, roughly. Similarly, if a patient is on azathioprine plus 5-ASA, maybe you can think about it now in terms of stopping either 5-ASA. Two large retrospective cohorts have come up, which have shown that stopping 5-ASA over a short-term period of 2 to 3 years did not make a difference. So 5-ASA has been thought to be chemopreventive. Till now, we have been giving it with the hope that it decreases the cancer risk. So the thing is that azathioprine also decreases inflammation, so possibly that would also decrease the cancer risk. So you can downgrade the medicines once you have achieved, shown that, okay, there is mucosal healing, clinical remission plus endoscopic remission. Again, you have to just one point, look into the past history of the patient. If the patient had a very aggressive disease and you achieved remission with a lot of difficulty, then I would suggest do not stop it. If the patient was doing reasonably well, then in that case, and it was not a very aggressive disease in the past, then you can think about stopping it. Then the chances of maintaining remission would be much higher.
Yeah, minute in between I'm asking. Suppose the patient is on 5-ASA, only on 5-ASA. So he's on clinical as well as the histological remission also. So is it possible to stop 5-ASA, or we should continue the 5-ASA minimum with one medication?
Minimum 5-ASA should be continued.
Yeah.
Except that if the patient has proctitis and 2 to 3 years of complete remission have been achieved, there you can think of stopping 5-ASAs also. Otherwise, at least 5-ASAs should be continued.
Yeah, that's what I also think, and there's a chance to at least we can reduce the chance of malignancy for future. I think that should be the message, that we should not stop the medicine altogether, so that in future we have some more complications with the malignancy.
Saurabh, back to you.
Thank you, sir. Thank you. So I would like to also have the opinion of our moderators, Dr. Sarkar, Dr. Joseph, and Dr. Amitabh on this aspect what we were discussing. What are your thoughts and what do you practice?
So my questions to Dr. Vineet, sir. So what should be the minimum dose for long-term maintenance for mesalamine? What we do is 2.4 we give. What can be the minimum dose for long-term once the patient recovered maybe after 5 years? What should be the bare minimum dose we can give?
I think it would be better to maintain 2.4. So if the patient was, let's say, upon 3.6 or 4.8, you may downgrade it to 2.4, but 2.4 would be optimal. Saurabh, maybe you can ask another question apart from treat to target.
Yeah, yes, sir. So now my question to Dr. Goswami. So, sir, it was an excellent talk. So now, for the audience, what would be your approach? So, for example, you have a patient, you find a colonic ulcers, and how do you approach them? And how do you decide whether it's TB, it's IBD, or it's any other etiology? So, what would be your overall approach for such a patient?
Yeah, first of all, if IBD, again on IBD, suppose ulcerative colitis, when you do the colonoscopy, so immediately, most of the time it is more or less obvious that it may be ulcerative colitis. Of course, you have to take the biopsy. But in case of a Crohn's disease, it is of course difficult unless it is involving the colon somewhere, from ileocecal valve to the even anorectal area. Then in tuberculosis, in the same way. But the point is ultimately you have to get the final diagnosis, which one we have got it. You have to depend upon the clinical picture as well. Some patient may have IBD or TB very commonly. In IBD, it may be the problem will be with the Crohn's disease versus it is the COGS. So your biopsy, clinical picture as well as your colonoscopic picture will give an indication which way it is going. Then what I have mentioned here, so beyond TB and beyond IBD, we have got a lot of ulcerations through non-steroidal anti-inflammatory drugs. Then we have got the amoebic ulcer. Then we have got the typhoid ulcer even. So these are already I have mentioned in the slides that ultimately you have to get the diagnosis, and most of the time we have to ultimately depend upon the biopsy and histology. Some other things, for example, pseudomembranous colitis, there the clinical picture is and history is also important one. Now, suppose the patient is already immunocompromised, elderly person, and colonoscopic picture in this group of patient probably will be helpful for us. Of course, ultimately we have to take the biopsy. Then radiation proctitis, again, the history will suggest, and after that you go for the biopsy to get the final diagnosis. But history itself talks about the radiotherapy plus chemotherapy, that will be ultimately some indication for the diagnosis. So that's why it depends upon which way the colonoscopic picture shows to us, then you give the importance to the clinical picture, history, and depends finally on the biopsy.
Thank you so much.
Can I ask one question?
Yeah.
Yeah, to the speakers, I mean, many times we see this, sometimes it's very difficult to differentiate functional versus IBD, and we do colonoscopy. And it's quite common that we see some colonic ulcers or ileal ulcers. Many times they are non-specific and clinically they don't fit into IBD. In those sort of patients, how would you go about, and when would you repeat a colonoscopy? How do you treat them?
Yeah, first of all, from my side, I have already mentioned about the non-specific colon ulcer. So where you cannot get any diagnosis, you take the biopsy, histology, no diagnosis, no cause is found out. So then we have to call it a non-specific ulcer, colon ulcer. But if it is the cause is found, then it is a completely different story. But repetition of the colonoscopy, I'm not sure. Probably Vineet can give some light on it. Vineet?
If you just picked up the ulcer as such, you were not suspecting anything like IBD, and you picked up some small ulcers, asymptomatic patient, you're doing a screening colonoscopy, then you can easily ignore it, take a biopsy and ignore it for a period of 1 year, and if required, you can go back. However, if the patient has been symptomatic and you find some deep ulcers, then not only you take biopsies, you would go like to proceed further and go in for see whether do a CT enterography or something like that to see if there are any other areas which are involved. And along with that, when you're doing that, then you would also looking at the histology. But if they're like say very small superficial ulcers, vague symptoms of abdominal pain and all that, then today you can also do a fecal calprotectin to differentiate whether the patient has some clear-cut inflammation or not. So 3 points basically, if you picked it up by chance, asymptomatic terminal ileal ulcers or superficial ulcers, then in that case you can just follow up the patient. Patient had some symptoms, you picked up ulcers, and the ulcers, particularly if they were deep, then you need to go the full way in terms of investigating. Do a biopsy, do a CT enterography. At times, you may also have to do a capsule endoscopy. If superficial ulcers, again, you are not very sure what it is happening, then you would just give a course of antibiotics and do a fecal calprotectin also to assess after 2 or 3 months whether there is ongoing inflammation. So that way, broadly, you will be able to divide your cases into some which require attention and those which do not.
Vineet, is there any guidelines to check or repeat the colonoscopy? Any time limit?
The guidelines in the sense, if you look at all the data available, then asymptomatic terminal ileitis, after 1 to 2 years, you may repeat a colonoscopy. But however, if it is symptomatic when we say is patient is having diarrhea, patient is having fever or having weight loss or blood loss or something like that, then you are dealing most likely with a disease entity, which could be tuberculosis, which could be Crohn's disease, or it could be any other disease entity like what Dr. Goswami showed. You have to take a biopsy to rule out a lymphoma. It could be a carcinoma tumor out there. This we are setting, it is talking about in the chronic setting. If suppose the patient has history of only 10 days, then the immediate thing would be amoebiasis or typhoid fever or Yersinia or something like that. If you're talking of somebody who's having symptoms from around 1 or 2 months, 3 months, then you go down the route of tuberculosis, Crohn's disease, lymphoma, eosinophilic enteritis, or rule out all the possible chronic causes of these kind of ulcers. I hope I've made it clear.
Yeah.
So,
Yes. So is there any role of CB-NAT when we are doing all these
yeah,
molecular
very
things?
always send a CB-NAT if you think that the ulcer is more than just simple superficial, because you not only take biopsy for histology, because one primary diagnosis you have to exclude is tuberculosis. So you would like to send gene expert or CB-NAT for the biopsy for that to rule out TB.
So I think now the organizers are requesting to wind up the session because the live workshop is about to start. So I would like to thank again our esteemed speakers, panelists, and moderators for this interesting session. Thank you very much.